Hello everyone and welcome to today's episode of Dine with Doc. I'm Dr. Sanjay Arora and I'm thrilled to be with you today. Today I have a very special guest, a dear friend and someone with whom I've been closely associated for over 2 decades. Dr. Rajiv Kovil is a pioneer in diabetes care but also advocates better public health policies to help nutrition for children. It's an honor to introduce Dr. Rajiv Kovil, who's a renowned diabetologist from Mumbai, and he's been at the forefront of many health initiatives. Rajiv, welcome to the podcast and thank you for joining me today.
Thank you so much, Sanjay. Thank you for bringing me here, and I hope I add some value to the conversation we have.
I wanted to make this conversation slightly different than what normally people speak about diabetes. But the first question is, India is called the diabetic capital of the world. But tell me, Rajiv, is it merely because we have so many people, so we become the capital of almost any medical condition, or is there genuinely some genetic predisposition or something in our lifestyle that makes us more prone for diabetes?
I think both are true. The numbers tell us that we are the second largest people with diabetes. But apart from that, the prevalence tells us that it's very prevalent in our population. So it's like genetics loads the gun,
Right.
and our lifestyle and the circumstances we live in pulls the trigger to it. Diabetes is I would say, is the end product of it. But there's a lot of genetic predisposition to fat distribution in Indians.
Okay.
And the bigger problem is that we store fat in organs where we should not be storing fat.
Okay.
And that becomes a liability. And this, if I can explain a little bit,
Yes.
is that India per se, a few centuries back, we were not getting food at all. So our genes were developed in a way that we could store fat. So
Okay.
that the next maybe 5 days, 7 days, you are not going to get food. So our liver genetically was such that it could store fat. Our muscles could store fat.
Okay.
Now, when this is an adaptive change, the genes adapt over centuries for this. And when this population gets surplus of energy or surplus of food, it is still being stored in an organ which was adaptive becomes maladaptive.
Okay.
So that's what has happened in India. So the rapid transformation which occurred from the mid 80s to now, which should have occurred over a period of 100-150 years, it occurred at a period of 15 to 20 years. So there was a rapid surplus of energy in terms of food and complete decline in activity. So a lot of places where food was naturally stored, or too much of food to be stored and too much of energy to be stored. So there has to be a leak. So sugar, obesity, cholesterol, all are byproducts.
So in a way, the economic progression of our system, our country, our economy, sort of outpaced the genetic evolution, so to say. We evolved genetically to store fat, but because we got surplus food, that sort of outpaced that. And as a result, we continue to store fat in, as you said, in organs like the liver much more than we need to.
Absolutely. So the transition which occurred rapidly rather than occurring over a slower period of time. So that late 80s to mid 90s is where the transition actually occurred, where the lower class used to go by either walk to work or stuff like that. And they started using motorized vehicles to
Right,
work.
right.
So that transition which occurred very fast in India.
Okay.
It should have occurred over a period of maybe 40-50 years, where the industrialization and the modernization, but that didn't happen.
Okay. So if the takeaway for the audience would be that we are genetically predisposed and we store fat more than we need to. So does that mean we need to alter our diet and our lifestyle in some way because of that?
We need to, because one needs to understand that whether you eat a carb or anything other than a protein, a carb or a fat is going to be stored as fat in your body.
Right.
So for you may feel that, I'm not eating fat, so how will fat come into my body? So whatever you eat is finally stored as fat in your body.
Right.
And we are predisposed to storing this fat. So for us, obviously the nutritional component goes away when you do all this. So
Okay.
people are ending up eating more macronutrients without actually giving a lot of thought to what is nutrition there.
Right.
So you're not putting our nutritional choices right.
Okay.
So we are putting in a lot more energy dense food, and the nutritional requirements are not met. So we end up having a lot of disorders.
So I see a lot of patients, I'm just trying to pick up on what you just said, that I see a lot of patients who look obviously healthy, but their hemoglobin is still not adequate. Exactly what you said, that they're eating a lot of food, but it does not contain the nutrients that are required, like iron or whatever, to improve their hemoglobin. Is that something what you're
You're
trying to say?
absolutely right. That when you have energy dense and poor nutritive food, you end up having a very dysfunctional metabolism, and
Right.
your gut is the gateway to your body. So a lot of, in future you'll have a lot of therapies which are treating the gut, and which will then prevent a lot of these NCDs.
Sure.
But a lot of food have become so ultra processed today that the absorption becomes easier, and the role of our naturally their gut microbiota is becoming lesser. So this is another problem.
Okay.
And we are not eating micronutrient dense food, and in turn we are getting obese, we are getting cancer, we are getting heart disease, adding on to the poor work life balance we have, the poor sleeping patterns we have, the stress everyone goes through. So obviously it's like a time bomb.
You also mentioned that Indians are predisposed. So is the fact that we all have a pot belly in India, at least the males in India have a pot belly, is that also something which stores a lot of fat in the abdomen?
So good that there's no gender differences in the pot belly.
really?
No,
Okay.
no, there's no gender differences.
Okay.
But this is what we call as thin fat Indian.
Okay.
So earlier we used to define obesity with probably a BMI or height weight ratio, or probably a waist circumference or stuff like that. But today it is your body composition analysis, your body
Right.
fat, and what is seen as this at the same BMI, and at any age group, a newborn child to an elderly male, a Indian has more body fat as compared to a age matched Caucasian.
Okay.
So this is known. So even a thin man with a BMI of 20 will have a pot belly, and that visceral adiposity is a genetic problem.
Right. So we do store more fat in organs. We have a higher ratio of fat. We eat a carbohydrate rich diet. We also don't exercise enough.
We don't exercise at all. So earlier, I mean, it has changed a lot. Fit India and so many movements have made exercise a culture in right now. But 20 years back, if somebody is walking on the road or going for a walk, so generally the comment was, "आपका तबीयत तो ठीक है ना? आप walk पे जा रहे हो?
Correct.
Are
Right.
you having diabetes?
Ah.
Are you having heart disease? Are you having
So
cholesterol?"
you are going for a walk only if you have a health issue.
Yeah, so preventive any kind of activity was never there.
Right.
Today people are doing it, but
Right.
2 decades back, nobody who was healthy was going for a walk. So
I know.
there's a change in that
Correct.
now.
So before we continue, I think let's try and get some micronutrients into our diet. So you've got some homemade salad.
Fantastic.
Please let's go ahead and start. A very favorite topic of mine, while the whole world is focusing on diabetes, I somehow feel we need to focus on pre-diabetes, because my thought process is that let's not add more diabetic people to the already very large population of diabetics, and let's focus on pre-diabetes. So I would like to know from you, what is your view on pre-diabetes? How do you define pre-diabetes? How do people identify themselves that I am a pre-diabetic, and then what can they do about it actually? Your view on pre-diabetes.
A very good question, Sanjay. Importantly, pre-diabetes is a transition between a person with normal control, blood sugar control, towards diabetes. And India is unique because obviously we are the second largest population with diabetes. But we are the largest population with pre-diabetes.
Really?
Yeah.
I didn't know that.
Yeah, we have 100 million people with diabetes and 126 million with pre-diabetes.
It's a larger population.
Larger pop. And the
So
transition.
in a way, it's an opportunity.
It's an opportunity. And the transition from pre-diabetes to diabetes is the highest. Also, according to the ICMR research, the pre-diabetes population is high. When you compare diabetes prevalence versus in rural versus urban, there is a difference, diabetes prevalence, rural
Sure.
versus urban. But pre-diabetes seems to be similar, which is very interesting. So we have more pre-diabetes in India as compared to many parts of the world, and there is no difference between the urban or the rural.
Okay.
So-
Whereas diabetes, of course,
Is almost similar. That means there are going to be more people transitioning from pre-diabetes to diabetes. So multiple reasons, but one simple reason that when I had gone to Ratnagiri 2 decades back, I'd seen an explosion of diabetes. And when I asked them, the fisherwomen used to walk for 10 kilometers carrying fish on their head for it to the market.
right.
And the husbands used to go in simple nets, smaller boats, and fish.
Correct.
But now they are motorized nets, so the catch is bigger.
Okay.
The women are no longer walking; they've got a rickshaw. They've become more richer. So overall, so it's not pre-diabetes or diabetes; it's obesity. It's obesity which is the mother of all this.
Okay.
Obesity is driving diabetes, heart disease, kidney disease, cancers across the globe. And this ectopic deposition of fat, when we see the definition of obesity can be very different. But when you look at percentage of fat and wrong deposition of fat, which causes a functional problem in your organs,
Right.
that's what obesity can cause.
So it's not just your BMI being below 25, but it is the percentage of fat.
It's also a percentage of fat. So you may have, there must be a person who's not a diabetic. There may be a person who is a pre-diabetic. There may be a person who, because of obesity, has got sleep apnea.
Right.
Somebody has a non-alcoholic fatty liver. Somebody has cancer. Somebody has heart failure. So all the problems of this abnormal deposition may not be there in one individual, or it could be there in an individual at a much lower level. But when you add those things in one individual, it becomes a huge cocktail.
So I guess the next topic for us to discuss after we do this is on obesity actually, which is probably the underlying cause for many more problems.
Absolutely.
But
India is growing fat.
So how do you identify pre-diabetes, and how do you educate people that how should they know they are part of that 120 million?
So it's very difficult. So most people, even in urban India, are caught pre-diabetes usually in an executive checkup.
So you get to know accidentally.
Accidentally. That's the bigger problem, because even diabetes doesn't cause symptoms. So pre-diabetes, there's no symptoms. And why we should treat pre-diabetes? Because not much of a difference of cardiovascular risk
Right.
between pre-diabetes and diabetes.
Sure.
So there are a lot of people out there who are pre-diabetics, and a general a prescription or an advice given to them that you are borderline. You do something and you should get fined. But that's not the thing. If you look at the larger setup, we have a huge population, out of which we have around 10 to 11% with diabetes and another 12% with pre-diabetes. So if
1/4 of our
is
population
dysglycemic.
right.
But if you look at the other way, if an optimist looks at it, will say that 75% of our population is normal. If a pessimist looks at it, say 25% of our population has.
But how should a realist look at it?
A realist should look at it saying that we have a huge population which is converting on a yearly basis.
Correct.
Which is the problem, and that conversion is occurring prematurely. Like if the diagnosis of diabetes or pre-diabetes is going down decades. So you're getting people with any kind of metabolic disorders younger, and they have to live longer
Right.
with that disorder, which obviously will get some premature complication. And it's not only for them, it's a ethical, medical, social need that we treat them fast or prevent their diagnosis for longer period of time.
So I have this condition that I've been trying to evangelize called unburdened healthcare. So basically what we are saying is we're just increasing the burden on our healthcare ecosystem.
Absolutely.
And when somebody does an executive health checkup or accidentally comes to know, is HbA1c, the reading of an HbA1c test indicates pre-diabetes?
Yes, any HbA1c between 5.7 to 6.4 is pre-diabetes.
Right.
And as per our guidelines, if a person remains in pre-diabetes in spite of best measures of his lifestyle in 6 months' time, then he should be on medication to prevent progression towards diabetes. But most of our patients are lost there.
when is the right age for someone to say, okay, I want to voluntarily get myself checked if I'm a pre-diabetic or not? Is there an age cutoff in your experience?
So I would say 25. It is 35 as per the government of India. I would say 25
25.
because diabetes, especially the kind of type 2 diabetes, there's a lot of heterogeneity. We are seeing very young onset type 2 diabetes.
Right. And if there are five people in a room, can we tell somebody that one person is more at risk of developing pre-diabetes?
No,
No.
no way. Because as I said, genetics and hereditary plays the role. But if you are overweight, your risk is higher. So it's all statistics there. And if you're underweight, your risk is lower, which doesn't prevent progression.
Right.
Because
It doesn't
even
mean
if
just
you're
because you're underweight, you will not become diabetic.
exactly, you may be
Right.
underweight, but with a lot of fat inside.
So I'm just trying to paraphrase your thinking that if you are overweight, if you have higher fat deposition, you have a family history, you are inactive, perhaps get yourself started getting checked at the age of 25. But if you are normal weight, you don't have a family history, perhaps you could delay the checkup. Could that be a
Not
little bit
really,
of guideline?
not
No?
really, not really, because India has this dichotomy. You have people dying of obesity related problems, and at the same side, you have patients dying of malnourishment also. Children dying of so you have
Sure.
obese children and malnourished children. So I think the rule has to be very, if it has to be implemented, it has to be
across the board.
across the board.
And another favorite topic of mine because of prediabetes, and as you said, individuals having an HbA1c between 5.7 and 6.4, and get yourself checked at the age of 25 and above. Once a year is good enough?
I think once a year is good enough,
Okay, okay.
but the year has to come every year, which never comes.
Right. What's the role of metformin? I know metformin is a great drug. I mean, it does so many things, not just for diabetes, but for metabolic health. If somebody is pre-diabetic, would you recommend, or is metformin recommended to them to prevent progression into diabetes?
So metformin is a repurposed drug. You know, it's been there for almost 75 years now.
Right.
And apart from diabetes, PCOS, pre-diabetes, rheumatoid arthritis, you have a lot more indications for metformin. And there's an ongoing study on metformin to prolong life also in the elderly. Longevity. So we don't know, a decade later metformin could be popped in as a pill by everyone. But as of today, after being there for 75 years and very little side effects other than from the GI and B12 malabsorption, it's a drug which an Indian could pop in to prevent diabetes. If he's a pre-diabetic, if he's a diabetic, if he has polycystic ovaries, very cheap drug, very easy drug. If you don't have chronic kidney disease, you do not have any adverse reaction to the drug, or don't have upper GI problems, it's a good drug to take.
So meaning, and you have been treating my parents for such a long time. My mom had diabetes, dad has diabetes. My HbA1c is 5.9. So do I become a good candidate for taking metformin?
So if you have put in all your measures for 6 months,
Right.
and if it doesn't change, then you're going to join that gang.
Right.
You know, so you have to take metformin, and it doesn't mean that if you pop in a metformin, then you don't have to do the other stuff.
No, you continue doing.
You continue doing. So the drug is added to the lifestyle. So
But will
lifestyle is the cornerstone.
Of course. But will it delay the progression?
It will delay.
It will delay.
It will delay the progression.
Okay. And I've also heard that metformin, and correct me if I'm wrong in this, that if there are 10 people in the room, 5 will respond well and 5 will not respond well. Is that a normal case? That
I wouldn't say 5, but I would say 6 will respond and 4 won't. And that's with every drug.
Okay.
So a day will come where we will, at the diagnosis of pre-diabetes and diabetes, we will draw blood, do a genetic testing, and tell you you're going to respond to this.
I was just going to ask you that is pharmacogenomics now become a reality?
Pharmacogenomics has become a reality in few form. Obviously in cancer and oncology it is very much there,
Right.
But in some forms of diabetes like monogenic diabetes, it's the way to go forward, because you are able to completely risk classify them, you are able to find out what drugs will work for them, and you're also able to prevent, and also the epigenetic transformation which occurs.
So in 100 patients that you see, I mean, how easily accepted is doing a genomic test for knowing your, doing a pharmacogenomic test accepted by your patients?
Cost becomes a factor. So if you in 100 patients, you may have just one or two MODY or monogenic diabetes.
Okay.
But at least one of them, like 1%, do undergo testing who's in the middle age group for genomic testing, and it's increasing. Cost has come down in the last 4 to 5 years, and if the
Right.
cost comes down, I think we could use it as a first line checkup.
What would be the cost that you think would be palatable?
Less than $5,000.
Okay. No, I think we are not too far from
You're not
that.
too far from
Actually,
that, no.
doing a pharmacogenomic test and specifically targeted for the diabetic population, I think we could bring it down to
Bring it down to
5,000.
that.
Okay, that's good to know. But currently for metformin, you are not saying it is essential, even though 4 out of 10 patients may not respond.
But we have a lot of other drugs to use now. Though we don't have an indication in pre-diabetes other than metformin and probably an alpha glucosidase inhibitor.
Right.
But the whole, yesterday I was speaking to an editor, and my thing was that when we say diabetes, we are talking about sugar affecting the retina, because the whole threshold for that sugar is based on the retina.
Right.
And that is the Caucasian way of looking at it. An Indian system or an Asian system, which is the organ which gets sensitized or which is the organ which gets first affected, we still don't know. We still don't know the level at which it affects organs in our body. That epidemiological research is not there in India.
But commonly you would expect kidney to be the one, right?
Could be kidney, could be eye, could be heart, we don't know. So
Okay, we
the
don't know.
point is that we don't know. We could have diabetes at 95 also. We don't know.
Right. Okay. And you mentioned monogenic diabetes. So maybe quickly, if you could just help us understand, we commonly know type 1 and type 2 diabetes, but we also know there is now type 3, and there is gestational diabetes, there is MODY, and there is
Type
latent
3C,
diabetes.
LADA. So,
Yeah.
so when you have a young onset diabetes, a person, when I say young, less than 30 years of age, there's a need for classifying him well.
Okay.
Because there's a lot of heterogeneity. So
Right.
just because he's come with weight loss and ketones in urine doesn't make him a type 1 diabetic.
Okay.
Just because he's not taken insulin doesn't make him a type 2 diabetic either.
Okay.
So you have to do some autoimmune studies. You have to see whether he's naturally making insulin or not. So
Sure.
C-peptide studies are there.
Sure.
Monogenic diabetes is one form where a single gene is involved. Type 2 diabetes is a difficult thing to crack in terms of a pharmacogenomic exercise because multiple genes are involved. Though now we've been able to zero down on a few genes,
Right.
but monogenic diabetes is easier because there's single gene involved,
Right.
and it runs in families. So you have a young onset diabetes at least in 3 generations.
Okay.
Most of them are people who do not have complications. They respond easily to the group of drugs called sulfonylureas.
Right.
And many a time we do this to prevent them being labeled as a type 1 diabetic, because many of them are taking insulin, and we don't withdraw the insulin till the genomic testings come, which may take up to 1.5 months to come sometimes.
Right. So you're saying if somebody is above 30, then you don't really dissect too much on classifying.
You can, because what happens is that this generational history is not sometimes very well kept.
Sure.
Your grandfather could have had diabetes, but you never knew. He was a young diabetic. He died at 40. You don't know what he died of.
Sure.
So if you suspect, and if you see his phenotype and see this guy doesn't look like a type 1, or we have some families. Family history doesn't mean directly your parent. Also, it's your family tree. If you have people with young onset diabetes, and many a time you don't remember the age of onset. So you have an uncle who's a diabetic for 30 years or 40 years. So that's a young onset diabetes in the family.
So 95% of the patients are type 2 diabetics. 2.5 lakh population in India is type 1 diabetics. I guess a very small percentage then falls into the other categories of diabetes, including gestational diabetes as well.
So when I say 95% are people, when I say etiological classification or etiopathological, where we know exactly is not being done. So if you have a young onset diabetes, a lot of times he's not been evaluated for monogenic diabetes or maturity onset. A lot of type 2 diabetics who progress to take insulin, are not actually evaluated for what we call as latent autoimmune
So maybe you
diabetes.
can just, briefly, as for a layperson, as our audience who's watching, just maybe help them understand what is monogenic, what is latent onset.
So monogenic, as the name suggests, you have one single gene defect, and this runs in families.
Okay.
So you have a young onset diabetes for 3 generations.
Okay.
LADA, as we call it, is called latent autoimmune diabetes in adults. So many a time you have young onset diabetes, sometimes below the age of 30 also, and you progress towards requiring insulin very fast.
Okay.
You have a young type 2 diabetes also without features of obesity.
Right.
Which means you have a very lean type 2 diabetic.
Sure.
You could have a obese young type 2 diabetes who are more insulin resistant and his sugar may not be high.
Right.
So there needs to be a classification in all of them so that we know what do we target in future.
And that's how you're saying clustering.
Yeah, that's why a clinical or what we call it as a phenotypic clustering is important for us to realize should I just chase his sugars?
Right.
Should I just chase his weight? Or there are other things I need to chase on?
Okay.
Because as a layperson, everyone thinks that diabetes means sugar, and you control the sugar means everything is all right.
Correct.
So it doesn't end and start there.
So, and I know this is very common, but most people don't understand this, that fat actually acts as a barrier for even your natural insulin to act. So, where does lifestyle management, continue to remain effective, and when do you know that, okay, lifestyle management is not going to cut it and there need to be some other support given to this patient?
So world over, when we talk about data, majority of people are not able to keep in real world data that 12 to 15 weeks is that people are able to continue a very strict lifestyle management.
Meaning 3 to 4 months.
3 to 4 months. After that, there is a lull period, and then when they see something abnormal, then they come back to it.
Right.
But the sustenance of a very strict lifestyle regime is 3 to 4 months.
Okay.
That's why we always tell patients that do things which are practical. As soon as the diagnosis comes,
which you can sustain.
Which you can sustain. It's not then otherwise you're going to have a rebound.
Right.
So even these lifestyle measures, even when a dietitian counsels you, you cannot make a 360-degree change in you because that's not going to sustain. So there's going to be a lot of practical things there that you're going to sustain. And also, when we say lifestyle measures, whatever activity you do, it is something that you should enjoy doing.
Correct.
Like you love cycling. That's an activity for which you enjoy doing. It's a passion and it helps you also.
Right.
So people should do activities which they like.
So like Anju, my wife, if she was, put in the same situation, she would not do cycling, as you said. Yeah.
Exactly.
So just prescribing a cycling will not be effective.
Absolutely.
In that case. True.
And taking a walk can be very monotonous for many people.
Right. So pure lifestyle management needs supplementation because it's not going to work for everybody.
Absolutely.
True. And what is this whole area around sugar substitutes? So we know that sugar is a culprit, or sugar sort of is the main root cause. So people say that replace sugar with jaggery or replace sugar with sugar alternates. What's been your experience? And we know that jaggery is of course common, but sugar substitutes are also known to have their own side effects. So what's your experience and what's your advice to patients on this?
So jaggery and sugar has the same caloric value.
Okay.
Jaggery has got some multiminerals. That's why people think it's to be healthy. But that's not the case.
It's not the case.
That's not the case.
So you have mithai made out of sugar and mithai made out of gur.
Is the same calorie content. Absolutely.
Okay.
And when we talk about non-sugar sweeteners or artificial sweeteners,
right.
Never has there been in the history of medicine the amount of scrutiny and vigilance which has occurred into this segment.
Right.
And the jury is still undecided on it. But a lot of drugs come and there are no pharmacovigilance on it. Nobody looks into what happens with this.
Right.
But last 50 years of them being there and a lot of beverage market actually utilizing it and growing big over it, there's been a lot of vigilance and scrutiny there.
Sure.
But at the recommended allowance that you can have, there have not been any serious side effects.
Okay.
A lot of times people consume everything in excess. You can have problems with anything good also.
Sure.
But in the in the recommended, I would say recommended, what is the toxic allowance or the maximum allowed intake. If you go beyond that, there will be problems.
But if someone says, I'll give up sugar and take a substitute, you're okay with that?
I'm okay with that. I'm okay with that. But many a time there are two schools of thought on this. There is one school of thought that it reduces your overall caloric intake, so your obesity goes down, your diabetes, blood pressure, everything goes down. Another school of thought which is also backed by science, and that's why science is always confusing. Another that you reduce on your natural sugars, your craving for it goes up, and then you end up compensating also.
Okay.
So there are two schools on that.
Sure. Okay.